3, 2, 1.
Hello, everybody. Welcome, welcome. Welcome to the Congenital Syphilis Learning series. I hope you all are in the right place. I'm going to give about 30 more seconds for people to come in and connect to audio before we get started. Welcome. If you're already in, settle in, get your coffee ready. We're in for a great hour. Okay. Great. I'm going to give another 15 seconds for people to start coming in before we get into the logistics of getting interpretation up and running. Okay. Okay, folks. As people are settling in, welcome to the Congenital Syphilis Learning Series Part 1. My name is Jing. I am here with my colleagues from Health Outreach Partners, Cindy Selmy and Elsie Hernandez, who you will see later. We are doing this in collaboration with Migrant Clinicians Network and the Washington State Health Department. I'm going to pass it over to Martha to get started on getting interpretation going.
Thank you, Jim. Welcome, everybody. This session is being simultaneously interpreted into Spanish. To switch your audio over to the Spanish channel, locate the globe-shaped icon. In the Zoom toolbar, click on the globe and select Spanish from your menu. Let's go ahead and go to the next slide. Thank you. To match what you are hearing to what you are seeing at the top of your screen, there's a tab labeled View Options or tabs labeled English or Espanol. If you have the View Options tab, click on it and a drop-down menu will appear where you can select the slide deck you prefer to see. If you have the most updated version of Zoom, the individual English and Spanish tabs should appear at the top of your screen where you can easily toggle between them. Thank you. Next slide.
Awesome. Thank you, Martha. As people are getting to the proper channels, oh, was it not made in Spanish? Yes, it can be. As people are getting to the proper channels, I do just want to get some of the housekeeping out of the way. We, the panelists and people involved, have no relevant financial relationships that relate to this presentation, nor do we have any financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products. As well as this presentation was supported by the federal grant from HRSA. We have no relevant financial relationships that were identified by any individuals with the ability to control content for this activity. In addition, we are offering continuing education credits. I think I went one ahead. Hold on, sorry, let me just move this. And I can't, that's okay. We are offering continuing education credits. MCN will be providing the credits. You will receive the confirmation of credits after you finish the post-session survey. The survey link will be dropped into the chat at the end of this webinar. Additionally, it's also linked to this Zoom call. So when you exit this call, the survey link will also pop up. The AAFP have reviewed Congenital Syphilis Learning Series, Webinar 1, we also call it Part 1, and deemed it acceptable for up to 1 live AAFP prescribed credit. If you have any questions, you can reach out to Renee at MCN for more information regarding this. Finally, let's get down to the nitty-gritty of the presentation, the meat and potatoes. As stated, my name is Jing. I'm with Health Outreach Partners. I'm accompanied by my colleagues, as stated, Cindy and Elsie. We are helping facilitate. We also are lucky enough to have Renee Edwards from Migrant Clinicians Network and also Victor Ruiz from the Washington State Health Department. Very quickly about Renee, she began her career as a Peace Corps volunteer in Honduras, which led her to public health. She worked at local, state, national, and international government agencies for over 20 years and now serves as the Director of Technical and Training Assistance at MCN. Renee's focus has been on infectious disease prevention, control, and surveillance, and clinician and community training, framed by a health equity, language access, and cultural humility lens. She is bilingual and holds a Master's of Public Health degree. And in addition to Renee, we are lucky enough to have Victor Ruiz. Victor was born in Gilroy, California, and grew up and spent most of his life in the central region of Washington State. He identifies as Latin American and Native American with the Yakima tribe. He graduated from Central Washington University with a Bachelor of Arts in Law and Justice, specializing in legal studies and sociology. He started his career in public health in HIV and STI prevention as a volunteer, promoting and educating people on HIV and STI prevention and connecting people to testing. He felt confident that public health was the career path that he wanted to take, so he started working as a field services consultant with the Washington State Department of Health in 2018. Through this experience as disease intervention specialist, Victor currently supervises the Care Connection team, a team of people who help pregnant people, people living with HIV and hepatitis C connect and engage with care in rural communities in Central Washington. Today, we're very broadly going to go over what is congenital syphilis, why is there an increase, and how this affects migratory and seasonal agricultural workers, MSAWs, and other underserved communities. Our objectives for this webinar today are to discuss changes to syphilis epidemiology in recent years and resulting in significant increases in congenital syphilis, describe risks for syphilis and congenital syphilis for MSAWs that identify as women, and methods to prevent congenital syphilis. And finally, we are going to practice critical thinking, problem solving, and decision-making ability using congenital syphilis case studies and local program examples. I need to slow down. With that being said, looking at the agenda today, we are going to review a brief syphilis and congenital syphilis overview. We are going to look at syphilis trends in the US. We are going to look at prenatal testing guidelines and recommendations and structural barriers to treatment and care. And I should say, we do want to answer questions as they come in. So if you're able, please use the Q&A function at the bottom. We will have folks answer them as they come in. If we're not able to get to them, we'll bank them, and we have plenty of time for questions as well at the end of this session. And so we can review them there as well. With that being said, I am going to hand it over to Victor.
Good morning, everyone. I just want to thumbs up, folks can hear me. I just want to say good morning. I'm going to go over this slide. What is syphilis? I want to also keep in mind that this is just a brief overview of syphilis. In the next webinar, we are actually going to go more in depth into each stage of syphilis and the treatment guidelines, and furthermore details with congenital syphilis. Syphilis is a bacterial sexually transmitted infection that is transmitted by skin-to-skin contact with a person who has a syphilis symptoms, such as a syphilitic sore. Transmission occurs on the type of sex folks are having. That includes vaginal, anal, or oral sex. Upon our interviews, when we discuss with providers and with clients, it is really important to kind of have the conversation on the type of sex folks are having to kind of figure out where those areas that more people are more likely to be exposed to, and should be tested in those areas for STIs, which includes gonorrhea, chlamydia, syphilis, HIV. There's been many myths about how syphilis is transmitted, and from what we do know, syphilis cannot be spread through casual contact with objects such as clothing, doorknobs, toilet seats, pools, etc. There's been a lot. I've heard a lot of stories, and it's just really interesting of what you hear. And these are some of the things that we do tell folks. You cannot transmit syphilis this way. And some folks might try to tend to argue with you, but from what we do know, based on research, these are the least possible way to transmit. The only way to know that folks have syphilis is to get a blood test to confirm and rule out that if you do have syphilis. We will go into further about testing, labs, and treatment in the next webinar. Uh, Syphilis is unique in that it has several different stages that it can be diagnosed, such as primary syphilis, secondary, early latent, late latent, tertiary, which includes neuroocular, auto. Each stage has different signs and symptoms, and we will we'll discuss briefly about it today, but we will go more in depth again next webinar. As we're going to go in the next few slides, the United States have increased in syphilis, and so you're going to start to see a lot more data and research. And as we go through, we just wanted to let folks know that these are data that's being presented to you all. Next slide, please. Congenital syphilis. CDC, the Center for Disease Control, case definition of congenital syphilis as it occurs when people pass syphilis to their babies during pregnancy. Syphilis that gets transmitted is typically not treated, or they get reinfected if the pregnant person has syphilis. Congenital syphilis is preventable if a pregnant person is tested and treated during pregnancy. We'll go into more about that in the next webinar. For folks who have untreated syphilis or actually, congenital syphilis occurs when untreated syphilis or person who gets reinfected with syphilis from an untreated partner during the pregnancy can cause some serious complications such as miscarriages, stillbirth, or even death. Babies can be born if they're untreated, but some few challenges may occur that they may be stillborn or may even die from the infection as a newborn baby. For those babies that are born with congenital syphilis, they can have deformed bones, enlarged liver, spleen, jaundice, brain and nerve problems such as blindness or death, and many other more complications. Like syphilis, congenital syphilis has been increasing through the United States. And we'll review in the next section, please. Next slide. And I'm going to hand it over to Raina.
Good afternoon, or perhaps good morning, depending on where you are in the country. Thanks for joining us today to learn more about congenital syphilis, which was very rare before 2019. All right, so just a word on this slide deck. Syphilis is a spirochete bacteria that is a bacteria that generally has the shape of a spiral, as you see on the right. The little stuffed STI bacteria on the left, you can get a whole set of those if you're doing education in the community, especially with young people. They tend to like them. Next slide. So I'm going to start out with a bit of good news. From 2022 to 23, the rate of reported primary and secondary syphilis did decrease. And potentially that is related to new and increased use of doxycycline as a post-exposure prophylaxis, known as doxy-PEP. We're not really going to dig into that today, but if you want to learn more, we will share the STI treatment guidelines, right? And you'll find out more there if you want to. So just a note, the slides that I'm going to share are from several Centers for Disease Control and Prevention decks on syphilis. Mostly they refer to primary and secondary syphilis cases because that is when people are most infectious. Some charts, though, also refer to all syphilis cases together, especially in slides about congenital syphilis, because vertical transmission or mother to baby can happen at any stage. So that said, let's continue. Next slide. During the period from 2014 to 2023, the largest percentage of primary and secondary syphilis cases were among men who have sex with men. So please don't consider this training a call to not focus on testing MSM or men in general, because the majority of cases are, in fact, still among men. During this 10-year period, the number of cases among MSM increased 41.8%, while the number of cases among men who have sex with women increased 410%. Thereby, for women, it increased 648%. So you see a whole chain reaction that happens as changes in epidemiology happen. And of note, if you look at this chart, on the green bar on the bottom, you see that for many years, women were the smallest number of cases. And then they moved in 2020 to being second after MSM. Next slide. The map on this slide shows a visual of the increase in rates for all primary and secondary syphilis cases in almost all states and territories from 2014 to 2023. We'll look at these maps again for primary and secondary syphilis among women and congenital syphilis rates as well.
Really
So
quick, Renee, if I could interrupt you.
Yes.
Just
Yes.
a note from the interpreters, if you could not use the acronyms. You
Oof,
just
I'll try not to.
I know.
Sorry.
Thank you. Thank you.
Okay. All right. So yes, take a look at your state folks and see what has happened in the past decade for you all and maybe your immediate neighbors. Next slide. Okay, the purpose of this image is to show the difference between the percent or proportion a particular racial group has of the total U.S. population, compared to the percent or proportion of primary and secondary syphilis that population has for those cases in the country. So that would be on the right side. And you can see that sometimes they swerve, they go up, they go down. Of note, we can see important disparities for African Americans and for American Indian and Alaskan Natives, accounting for a much higher percent of cases compared to the size of the population. So I'd like to draw attention here, though, to the Hispanic and Latino population, who make up the majority of migratory and seasonal agricultural workers. Overall, the rate is not disproportionate to the size of the population. But you'll see in a moment that the rate for congenital syphilis is disproportionate, or much larger than it should be for the size of the population, indicating that pregnant Hispanic and Latino individuals are not adequately tested or treated. Next slide. So the next set of slides will focus on syphilis among people who identified as women in their case reports. The data does not distinguish between cisgender women and transgender women. It's all people that identified just as women when they tested. So I cannot break that information out. So we see here that the highest rates of primary and secondary syphilis are among women of reproductive age. That is when they are most likely to become pregnant, which then creates an increased risk for congenital syphilis. And it has grown, as you can see, much over the past decade. We do see a small decrease, as mentioned earlier, in 2022 to 23, and we hope that by putting more attention on women for testing, to see a continued downward trend in the coming years. Next slide. All right, so this set of maps, like the one we saw earlier, shows a visual of the increase in syphilis across the country from 2014 to 2023, in this case for women. And you can see that the changes on this map are even more drastic, as much more of the country has a darker shade of blue. Again, take a quick look at your state, see where it's at. Next slide. Okay, so from as all these 2014 to 2023, the largest percentage of primary and secondary syphilis cases among women were reported among non-Hispanic white women, which is the largest population in our country at this time. But you note here that the reported cases of primary and secondary syphilis among Hispanic and Latina women, again, the green bar, is the lowest among all populations in through 2022. So as mentioned, keep this in mind when we look at the slide for congenital syphilis. Next slide. Okay, so let's get to the point on some data on that. Next slide. All right, there's kind of a lot going on in this chart, but let's take a look. The blue bars show the number of reported cases of congenital syphilis growing from 462 cases in 2014 to more than 8 times as many cases at 3,882 cases in 2023. That is an increase of over 740%. The dotted line shows the growth in all stages of syphilis among women, and the solid line at the bottom shows the growth of primary and secondary syphilis during this time period. We'll dig in deeper, as Victor said, on syphilis staging and what that means for pregnant women and risks of vertical transmission or mother to baby in the next webinar in the series next week. Next slide. So as we saw earlier, there have been significant increases with all the other kinds of syphilis, and here we see a map of congenital syphilis changes from 2014 to 2023. Next slide. All right, in this another slide of wavy bars, we see here the disproportionate percent of cases of congenital syphilis, again the green bar, for Hispanic and Latino cases, African American in the Black community, and American Indian and Alaskan Native communities as well. That is, there are many more cases than would be expected for the size of the population. White and Asian communities show significantly fewer cases compared to the overall size of the population. Earlier, we saw Hispanic and Latino women with the lowest proportion of syphilis cases. Yet here, we see babies of Hispanic and Latino parents have the highest proportion of congenital syphilis. So again, Hispanic and Latino people are not being tested or treated adequately to prevent congenital syphilis, or we would not see this disproportionate outcome. Next slide. Here's a little different way of looking at it. That might be some ways some of you who see epidemiology are more familiar with. The total number of cases are on the right, compared to the rate per 100,000 population on the left. Rates help us understand the difference between different size populations by looking at how many cases are born for every 100,000 people in that population. So we see here that there are many more cases among Hispanic and Latinos, Black and African American populations, but the rate on the left-hand side for American Indian and Alaskan Natives, Native Hawaiians, and Pacific Islanders is much larger for what are very small total population sizes in our country. So with that, I'd like to point out that while our focus today is on migratory and seasonal agricultural workers who mostly identify as Hispanic and Latino, if your clinic serves American Indian and Alaskan Native, Native Hawaiian and Pacific Islander, or Black and African American communities, please take extra care with them as well, because their risk for exposure to syphilis and a potential congenital syphilis outcome is much higher than it should be as a result of social determinants of health, historical and medical trauma, and many reasons beyond an individual's control. Next slide. So why is this even important? In 2023, there were 252 congenital syphilis-related stillbirths reported. That's an increase of 800% since 2014. And in 2023, there were 27 congenital syphilis-related neonatal and infant deaths that were reported. That's an increase of 237.5%. These are the most serious potential outcomes of congenital syphilis. For infants that survive a congenital syphilis diagnosis, there are many other health problems that can affect their development, growth, and health potentially for the rest of their lives. And congenital syphilis is 100% preventable through testing, correct staging, and appropriate and complete treatment. 100% preventable. None of those needed to happen. Next slide. So let's talk about how health centers can help improve these outcomes in the future. Next slide. To be clear, community health centers have an important role in STI testing. As you can see from this slide, most people diagnosed with syphilis and incidentally other sexually transmitted infections are not diagnosed in an sexually transmitted disease clinic. When I researched where people went at my last job in Detroit, they were mostly going to the emergency room, right? Because I could see that there were many more cases than who came to our clinic. So going to the emergency room is a poor use of time, effort, and expense for both the patients and the emergency room staff. Community health centers are in a prime position to make testing easier for patients by talking with them about their sexual health as a standard practice and making testing and treatment available in a convenient location. So please don't wait for patients to ask for testing because few will ask. Try to initiate conversations with your clients about their sexual health, at least when they have a new patient appointment, and then as needed based on information they share with you. But never miss an opportunity to talk with pregnant patients to learn about their relationships and sexual practices. Next slide. All right, here's another complicated one. We're going to work through it little by little and sort of look at the gaps where community health centers might be able to help fill in. We're going to move from left to right, and just starting with that big blue bar that's on the left-hand side. Those are all of the cases that happened in 2023, 3,882 of them. If you move over now to the right, the first column, in the orangish red box, there are 42% of cases of those who didn't have a timely test reported. And in the little blue bar underneath, who had a seroconversion later in their pregnancy. So perhaps they did have a test in their first trimester, but then became infected later on. Perhaps they went back to a partner or they got a new partner. Something happened after that first test. And then finally, just under half actually had a timely test documented. And labs are they're required by law to report syphilis positives to their state health department. So even if a clinician didn't report the case, the lab would have had to. So there's a lot of missed opportunities there. Moving on to the next column to the right, the first little orange box, we see that of those who did have a timely test, 22% had no documented treatment, no treatment. And then under that in the purple box is inadequate treatment. So perhaps they weren't staged properly. So maybe they got one shot instead of three, or maybe they just weren't able to come back for whatever reason. And you'll hear a case about that was difficult for someone with Victor. And then finally, 9% of those actually had adequate treatment, right? So then still, again, something went wrong after that treatment for the baby to have congenital syphilis. All right, and there's many barriers at each step that are often related to structural and systemic issues like housing, healthcare access, and along with other clusters of health conditions called syndemics that are made worse by each other. For example, substance use disorders. And these issues require a lot of coordinated effort to help someone get into care for whatever all is happening with them. Community health centers often have a lot of those services in one place, so it's a great way to help bridge those gaps for farm workers and other vulnerable communities who may not have transportation to go here and there. Next slide. Okay, so I'm going to talk a little bit about prenatal testing in your state. So if you know what the prenatal testing laws in your state are, go ahead and put it in the chat. List your state and then the trimesters when testing is required. If you don't know, that's okay, because you can look it up. We will share this resource, the prenatal syphilis screening laws in the United States. Let's see if anyone's in the chat. Don't see anything going on. It's okay. So if you have a patient who you know has increased, well, okay, let me just go through this slide. And when I looked at this document, I saw and was shocked that there are 7 states that do not require any testing for syphilis during pregnancy. I really didn't expect to find that. I only knew the states that I had lived in. Yes, I see a bunch of states dropping in here. Excellent. I'm glad to know that people are aware. Now, 43 states require testing in the first trimester, 18 required in the third trimester, and 5 more if the person has specific circumstances that increase their risk. 7 states require testing at delivery, with 8 more if the person has extra risk. And so how will you know if your patient has increased risk? Taking a complete sexual history will be critical to understand your patient's history and what may be relevant for them. And it may take time to develop trust so they can feel safe and open up to you. So be sure to talk to them also about any substance use issues they may have as well, or things that are happening with them or their partners. Again, when I worked in Detroit, we were trying to understand the increase in congenital syphilis and what was happening. And one of the things that we came across was that some people delay prenatal care because they have a substance use disorder, or they just don't get prenatal care at all because they're afraid to go in and get in trouble for using while they're pregnant. Similarly, I found a study that was comparing factors that contribute to increases in congenital syphilis in Florida. Some of the things that they found were reinfection after treatment. So like I said, someone may get treated and then they go back to a partner, they get a new partner, and then they get reinfected. And so some of them may also have a negative test, say in their first test, but then end up positive in the 3rd trimester. Again, something similar could happen. And then finally, they found an increase in reported drug use, which again often relates to late or no prenatal care. And so testing those folks at delivery is really important. Next slide. All right, some basic considerations for all the clinicians in the room. Once you have a sexual history from your patient, you may need to offer testing in addition to those minimum requirements based on their specific circumstances. And it might be more than what your state requires. Be sure to ask your pregnant patients, especially if they are new to you, if and when they had their last syphilis test, what the result was, and any treatment they may have received. That big shot of bicillin is pretty uncomfortable, so that's not likely to be forgotten anytime soon. And then it's really critical to ensure that if they test positive, they have completed treatment based on their stage. And don't be shy. If you need support staging, it's not simple. Your local health department or your state health department will be happy to help in a variety of ways. From staging, and maybe they can even look up, because test results sometimes are from a previous diagnosis, they can confirm whether or not the person has a known treatment or not. They might be able to provide treatment for you. Some health departments are able to share bicillin if you don't happen to have that in your facility. And sometimes they will even go out to find patients and give them the treatment in another place that's convenient for them. But it really depends on the health department. Some health departments are very small and are not able to provide a lot of extra support. Some are better funded, and people just don't always know what they can get with the STD, or a sexually transmitted disease department. And then finally, they'll make sure that their partners get tested and treated, right? So you can go and this is not a normal activity for community health centers, but health departments are required by law to try to find partners and get them tested and treated. So this is an extra benefit, again, to try to prevent those cases where someone goes back to their partner and gets reinfected. Next slide. Okay. Moving on from epidemiology, if I haven't killed you all with death by epidemiology, Victor Ruiz from Washington State Department of Health will share his experience working in the field. Victor?
Thank you. And I do want to appreciate and be grateful for all those who have participated in the chat, been able to kind of give us a sense of where you're at and what your state does offer in terms of testing for folks, syphilis and pregnant people. So keep it on coming. It's really good just to see it. I feel alive when I see a lot of people and their information, just to kind of see, the difference between Washington State and other states. So I want to appreciate and thank you all for that. Before I get into more detail, I do want to kind of describe this type of work that I do with myself, my team, and those around me in Washington State. I am a Care Connector coordinator who works in the Office of Infectious Disease at the Washington State Department of Health. I supervise a team that primarily focuses on working with clients, patients who test positive for syphilis and are pregnant. This team was formed from the local health jurisdictions coming together and discussing their county needs and how can we be able to help support them. In terms of this is a new team from the last year and a half that we've been working together with on a county level in 3 different counties, primarily in eastern central Washington, where we see the higher volume of congenital syphilis and syphilis in pregnant people. So we've been doing the work. We wear many hats, and one of our hats that we do wear is being a disease investigation specialist. Each state has their own DIS, which is disease intervention specialist, or healthcare worker, or local health jurisdiction investigating STIs and HIV. When we receive a case report, we begin our investigation to work with the provider to ensure that the client was adequately treated for their stage diagnosis of syphilis. What that also does is we're communicating with the provider to ensure that are the patients established patients, what was the reason for visit, just so that way we can be able to kind of get a sense of type risk factors that clients themselves are facing. When we do receive that case report, we automatically begin investigation. When we do interview and reach out to the client, we interview to figure out who all might have syphilis or might have been exposed to syphilis. We're kind of essentially, we're not, we tell a lot of clients we're not the sex police, nobody's in trouble. Our job is here to help intervene in spread of the communicable infection. We also, our team does offer syphilis and HIV testing in the field. We do know that there are many barriers that folks face, whether in terms of going to a provider, feeling comfortable, confident, or being able to trust kind of the government in a way. Some folks, choose not to stay in care. So our job is to kind of figure out how can we engage them into care or testing. And one of them that we do, we're able to test in the field, whether it's, their house, in the car. There's been several different locations that we're able to, but our main job is to kind of, the moment we have the partner to, the pregnant person, we're able to also interview them as well. We want to be able to let them know the consequences of not getting treated for syphilis and the possibility of reinfection to their partner if they are sexually active during the pregnancy. From the interview, we do also offer transportation to the pregnant person to and from their appointment. We do realize in rural areas that there are some challenges in terms of transportation. Not being one barrier is not being able to make it to their OB appointment. So with our team, we're able to take them to and from to keep them engaged with their with the provider and OB care. We also are able to work with the provider to ensure that they are testing third trimester and upon birth, just to look at their labs to avoid any reinfection, or if we notice any reinfection. So we work with, all together with the provider, the client, to ensure that the client is receiving the best possible care and that they're not having to be stressed about how are they going to get to their appointment, or how, what are they going to do to pay for the treatment. So we do work side by side with providers, local health jurisdictions, and the clients. There are times though that we do receive phone calls from providers, or we reach out to them and they're unable to reach out to a patient who is newly pregnant, went in for prenatal care. However, they test positive for syphilis and are not able to get a hold of. So our team does do many field visits out to the provided information. We do our investigation to kind of figure out where they might also be at in times of just to really connect with the clients and really engage them re-engage them into care. Another focus that this team does work is we work with people living with HIV who are lost to care or have fallen out of care. So our job is to work with their provider to ensure and get them re-engaged back into care, see what's going on with them. Uh, there's a lot of times where folks aren't ready, or if they are ready, how can we support them? And transportation being one of them as well. We are recently been working with folks who do test positive for Hep C, and we engage them into care. So we want to just be able to kind of just kind of give an idea of like how we engage folks. For Hep C, it's kind of fairly new for us, so we're still engaging in care. I just kind of wanted to give that insight of the scope of work that myself and my team does with the Washington State Department of Health. While working with this population, we want to let folks know that we still do not have any good national data for syphilis in this population. A lot of information that we gathered that are going to be pertaining to the next slide. Then the next slide that we just want to let folks know that these are actually coming from personal interviews that we've interviewed folks. So we just would like to acknowledge that syphilis in migratory and seasonal agricultural workers, although there's not enough good data to present to you all today, but we do want to let you know based on our interviews itself that we do gather this information, which is going to be presented on the next few slides. So just keep in mind that we can gather data, but a lot of information that we do get is from word of mouth from clients that say that they do work in agricultural field, in the agricultural world. They work in a warehouse or the fields out in the work. So when we do work with clients, we do try to ask as much more questions than what's actually being presented in data. Next slide. So one of the things that we did kind of when we created this list for syphilis and migratory, apologize, I'm saying that wrong, in migratory and seasonal agricultural workers is that these are some barriers that folks do have in terms of communicating with providers, engaging in care. They have similar risk as everyone else does. Transportation being a huge one. There's to and from either the provider or to a local health jurisdiction or somewhere to get tested. The lack of health insurance. A lot of folks do have concerns that they don't go in because they don't have insurance. There are some programs that are able out there to be able to help them out, but if without them knowing, a lot of us has to go out there and provide that education to them and see how can we engage them into care or with a program that's that may be able to assist them. Language has been a big barrier for clients because when they do arrive, sometimes if there's not an interpreter present, things do get confused for some of the clients and not knowing what's going on. We do have clients who do test positive for syphilis, and with the language barrier, they don't know what's going on. When during our interviews, we do have to sit down and really go in depth with the clients and provide more further education so that they're able to understand what syphilis is, what it means to be treated, what is the possibility of reinfection. So that plays a lot part, a huge barrier for clients. If there's not, language not being provided, an interpreter, then a lot of folks choose not to go, or may not seem like they're getting the best possible care. And these are just kind of references from what clients have told us. A lot of folks are frequently relocating, either from county to county, state to state. These are kind of some of the risk factors that folks are facing. Immigration status, and it's also going to tie into fear of government officials. A lot of folks, when we do approach, we have to automatically let them know, hey, we are from the Department of Health. We are, nobody's in trouble. We're here to help you out in regards to important health matter. And we have to be able to gain their trust. And that is really key because if you have the first few moments and if folks see a badge or if you're presenting yourself in kind of an intimidating way or in kind of a way that makes someone uncomfortable, they're not going to want to talk to you. So the number one thing that we tell our staff is to really, really rest assured confidentiality is really there for the client. We want to make sure that we don't share their information. Of course, we don't. We want to make sure that they feel as comfortable as they can before we interview them or ask a lot of questions pertaining to syphilis. If we're able to do that and start to build rapport, then we're able to get as much information from the client than we have in the past. So we're still trying to make sure that confidentiality is key amongst clients when it comes into immigration status, if you're government officials. People feel that we might share their information, and we rest assure them that we don't. And one of the questions is, what questions or concerns might you have for us? And that's, a few, number one. And number two is being reported to the police, being reported to immigration. Also increased risk of sexual and gender violence has been also a risk factor that we did see. One thing that I also wanted to bring up is cultural upbringings. In these counties that we do serve and across the state, cultural upbringings has to be very has folks have to be able to talk to clients, because some folks who are grew up in a certain area feel that they they are not able to talk about sex. They're not able to talk about STIs, HIV. So we have to be able to find a way to have those cultural conversations with folks so that way it's being respected on their end. So we start to build these conversations with clients and on my staff and staff around to let them know cultural. We want to be as much respectful to one's culture than anything else, to not disrespect it and be able to earn their trust. Next slide. So I wanted to kind of give you a sense of a story to share that took a lot of work in Central Washington and Central Oregon. So right here is just, sorry, I meant to say this is a map of Central Washington and Central Oregon. The climate additionally has high desert, and while distances on the map may appear short, there are huge mountains and passes that you need in order to take to travel. Additionally, this is a rural region with clinics few and far in between. So I'm going to just let folks know that this is kind of a nice area of Washington State. However, sometimes if we need a client to be seen or transported, it can take up to, half a day to a full day's worth of work. But our role is, as long as we're able to engage clients in care, we've been successful at that. Now I want to kind of share a story that occurred a while ago. A person who identified as a cis female tested positive for syphilis with the antibody test reactive with a reflex test of an RPR from an outstate laboratory. The patient was in an out-of-state, was in jail, and actually had reported that they lived in Washington State, is how we got the case report. And from there, we kind of, as soon as we got the case report, we kind of evaluated what was the patient tested for, what's kind of going on. We found out that the patient was, I believe, 23 weeks pregnant, received no prenatal care, and there was an ultrasound done to confirm that she was pregnant. The patient, according to the medical record, reported no history of syphilis and had not had a more recent HIV test. Other labs that were reported that the patient did test positive for a substance use. Patient did report living with their parents in Washington State in a county. However, when reaching out and doing a field visit, that patient's mother did say that they did not know and have not seen the patient. When we're talking in regards of reaching out to, part of our role is when we reach out to providers, it is really important that we kind of gather as much information from that provider based on their history to determine, risk factors, to determine if they have an established primary care physician. So a lot of these, when we're reaching out to the providers in order to discuss this patient and treatment, we ask a lot of these thorough questions just to make sure that the patient is receiving adequate care. When the case was transferred over to Washington State, DOH field service staff the Department of Health did receive a case report, and a field service consultant from Western Washington had got together with a field service staff member from Central Washington, and they were kind of doing some digging and looking for this client. They noticed that she had moved back to Washington State, but she's not been able to been located, just based off of knowing that we had found out part of our investigations that she was homeless, unstable housing. So what some of our field service staff did was able to kind of go through social media, kind of get a sense of what she looks like, what kind of personable information that she is sharing on social media. Is she staying at a certain area, such as a certain city, a certain location that she repeats to going over? We want to make sure that we're able to kind of locate where she might be. In that saying, our DIS, our field service staff, went out there and went on foot looking for the client for 2 weeks, kind of asking around, where do people go for if they're, homeless, if they're unstable housing? Is there a certain area? The field service consultants were able to work with the county, the police department, and tribal police and find out certain locations where folks were living and staying. So the team was able to go out there and be able to ask around, look and see. Now that we have a kind of an image of what the client looks like based on social media, they're able to kind of look and ask around in these encampments, to see if anybody has seen her. It did take a lot of work, but we were able to uh, find out that she was not there. She was living in a smaller city nearby, and we reached out to her per social media, that we were able to say, hey, we're trying to reach out to you in regards to important health matter. Please contact us. Our staff was able to get in contact with her, and we discussed about what kind of is going on. What can we do to help support you? And there's a hand raised before I go further. Do we do questions now or?
We'll do it at the end.
Okay.
Yeah, if people can submit their questions either in the chat or Q&A box, that would be great.
Okay. Sorry about that. And when we were able to get a hold of the client, we kind of wanted to ask, what can we do to help engage you in treatment for yourself and your partner? She was not insured. The patient did not have a primary care. And so we were able to offer, and her partner did not have any health insurance. They also mentioned they did not have any transportation to getting to their appointment for treatment. So we did offer that we would be able to provide transportation to them if they're willing to agree to meet with us and able to test. Now we were able to meet with them, ask them, answer any questions they did. I did want to keep folks in mind that because the small rural area they were staying in, for both investigators, it do take about an hour plus to get there. And so transportation in the winter time, this was winter time, really took a toll on us. The patient did kind of ask questions that because they were living in their vehicle, if they were able to be provided after receiving treatment and testing partner, were they able to be able to go where their vehicle was towed and get back and be dropped off where they were staying at. We did agree to help them out because we do know that folks who do live in their vehicle, this is all they got. And if it gets towed away and a lot of personal items are in there, what can we do? How can we help support you to gather those materials and then kind of get established and develop a plan of to get you treated? After the first treatment, we did let the partner know our client that you do need to be treated as a latent stage for syphilis. Keep in mind that you have to go in once a week for 3 weeks. Unfortunately, we in between the first dose and second dose, there was a snowstorm that developed on multiple highways that were shut down. So we weren't able to get her to her appointment. And at that point, we did kind of let her know that we do have to engage her into prenatal care and have to start treatment all over again. With that being said, we did stop hearing from the client. So then myself and my team went out there, waiting for hours to kind of locate, where this OP might be at. We knew a location where she was staying at, but she was not there. So we kind of waited out there, hours just waiting to see if she did show back to the house. She did end up showing back up. We were able to provide the lab results for her partner, and making sure that he was also treated. From there, we wanted to make sure, we wanted to make sure that they understood that there's the possibility if one partner is positive for syphilis, there's still the possibility that the other partner can be reinfected. We really want to dive in on the possibility of reinfection for both, even though if one's tested and treated, the other one, if they're not, we want to make sure that folks know, hey, there's still possibility, because in the next webinar, we're going to find out that syphilis, once exposed, it can take up to 90 days before you show positive on a test or on a positive on test or symptom within that 90 days. I do kind of want to wrap up a little bit more. We were able to get folks, we were able to locate the client and engage her into prenatal care, but unfortunately it was getting so close to her due date that we had to contact the local health jurisdiction from there and work with a major city hospital to let them know, hey, there's a possibility that this baby, because mom wasn't adequately treated in a timely manner, that we would like you all to monitor both of them and rest assured that they don't get rest assured that they're okay, they're being taken care of. We did hear back from them. They were successfully transported to the major city hospital. Been they were treated adequately, both her and the baby. We wanted to let folks know the father of the baby did reach out and shared photos of the baby. So this just kind of gives you a sense of, in these rural areas, of how sometimes, weather can play a factor, transportation, communication. If folks don't have phones, how can we communicate? And another way that we do use is social media. So just kind of briefly give you the extent that we take in making sure that we can connect folks to care. And I'm glad and fortunate this patient was able to continue to stay with us, and communicate with us. All right, next slide, please. Some of the barriers, kind of I went through, wanted to let folks know, the lack of reliable transportation, lack of stable housing and ability to stay in one place. Sometimes it takes us to go out there and look for them on foot, day after day, to make sure that we're able to reach out to those clients. The lack of community resources in rural settings, healthcare access points, the legal system and issue that arises being incarcerated, mental health issues, and due to past traumas around healthcare and previous pregnancies, substance use disorder, and as well the weather, as we kind of one kind of mentioned. I know we're kind of for time. If folks want to put in the chat, what are the other barriers that some people may experience or that you've had clients experience? If you don't mind, place them in the chat. And we can kind of go on to the next slide. As we close out today's webinar, I would like to review a brief summary. Oh, oh, no. Okay, I'd like to review a brief summary. As a lot of you seen that syphilis and congenital syphilis are increasing rapidly across the country. There's a lot of work to be done all around to intervene in the spread of this infection. Many vulnerable communities are disproportionately affected by these conditions, which we highly recommend testing for syphilis during pregnancy to ensure clients are being followed up. Although there are many challenges, there's still many opportunities in the healthcare system to prevent and lower the number of people affected. Next slide.
Thank you so much, Victor. Sorry, I'm trying to advance the slide and it doesn't want to move. Okay, folks, I know we are about a minute over. We are gonna wrap up. Our next session will be on Wednesday, January 29th at 10 a.m. Pacific time, 1 p.m. Eastern time. We're gonna have our lovely Victor back to continue on this topic, and we will also have Benjamin Miana, who is also with the Washington State Department of Health. If you have the time to stay and get your question answered, we would love to answer the questions that came in through the Q&A. I don't think it'll be any more than 5 more minutes. So if folks want to stay on the call to hear the questions I'll pose to Renee and Victor, that'd be great. Sorry, I was speaking fast. Cindy has dropped the Survey Monkey link in the chat. If you could please fill that out, we really appreciate the feedback. It's also required if you need the continuing education credits. Additionally, there has been a PDF that has been dropped in the chat as well. It links to pretty much everything, every data point that was referenced by Renee and Victor in this presentation, so you all can have that. Sorry, post-session emails will go out. You will all get the slides, and that packet will be attached as well, just for those who did not get it. With that being said, I'm very quickly going to ask Victor and Renee some questions that we got in the Q&A because I think they are important. I think this might be the easiest question to ask so far is, Victor, this is for you. What social media app did disease intervention specialists use in the Washington State case to find that patient?
So we use Facebook. A lot of time folks post things on what they want to find out, what they want people to know. So basically with social media, a lot of folks post, I'm pregnant, or I'm got married, and a lot of great news to share it. And a lot of times if folks don't put their profile on private, then it's public information. So now we get a sense of what the patient looks like, who potentially are partners, similar for Instagram. So we do a real good job using the social media and be like, oh, this is who we're looking for. This is where they might be hanging out at.
And I'll just add too, when I worked for the city of Detroit, we often found people in a lot of different social media. And I honestly, because I don't use it, don't remember all the names. But my kids, when I was like, oh, we found someone like searching on this, and my kids were like, yeah, young people don't use Facebook anymore. So, right, you have to, you try any of them. You might find someone there's gaming social media that are really specific to that. There are a couple others too, and there's always something new. So, check with your staff and see what's all available and try anything. You might find them somewhere.
Thank you all for that. There was a question we got in the chat. I think this could potentially be a quicker answer as well. Victor, what was the perception of the client about testing with the case study? And also, how do you measure health-related quality of life before and after treatment?
That's a really good question. The client was very receptive of testing. But because she was kind of nervous of talking to us in the beginning. She kind of thought that we might turn her in, get in trouble because of her substance use and the choices she has made in the past. We had to rest assured, like, we're not here to get you in trouble. We're here to assist you. What can we do to help you engage? And we had to focus on the baby and make sure that the mother understood and the father of the baby understood that this is a baby that could potentially die if not adequately treated. So we have to really kind of figure out and get a sense of what mother is doing. Same with the father of the baby. Father of the baby was really like for it. He did mention that, hey, we do use, but now that we're pregnant, I'm stopping to use and I'm looking to get into treatment. So it was really good all around to have those conversations. It's just a matter of transporting them to and from their appointments.
Great. Thank you, Victor. We got another question. I'm saving the biggest one for last because I think it'll facilitate conversation. I just lost the question. Oh, is there data on the number of clients engaged in congenital syphilis cases averted for this product? Is Washington State tracking that?
We're That is a good question. A lot of what I've had to do more recently was go back and look at each individual case, look at the outcome. Those cases that were considered congenital syphilis, where folks were not in prenatal care, um, who also just choose not to. Or they did receive one dose of the bisulin injection, but refused to go get a second or third dose. So they weren't adequately treated. And we're able to work with providers and ensure that the baby gets treated if mom's refusing.
Okay. I got a Spanish question. I'm going to try my best to translate it. ¿Se puede prevenir el sífilis con anticonceptivos? So are you able to prevent syphilis with anticonceptives?
No, that only prevents pregnancy. And so in order to prevent sexually transmitted infections, in addition to pregnancy, you either need to use a condom along with birth control, or you have to do other things to get tested, to make sure that you're doing okay. But there are some things, like I mentioned earlier, doxypep, that is a treatment that someone could take, especially if they're doing sex work, or they have other kind of factors, or they have a partner with many partners, that they can have that available to them. And then lastly, there's HIV pre-exposure prophylaxis that could be taken, if someone has a risk for HIV as well. And that's taking a pill every day. And there's injections also that are available as well, though that's a little bit less available than the pills.
Thank you, Renee. I'm gonna hit our, I'm sure, question that will incite a lot of conversation. We got a question asking to talk a little bit about why so many pregnant people are not being tested for syphilis, looking at that earlier figure at document tested. Is it providers forgetting, unaware of laws, assume patients don't have syphilis? Are people refusing, pregnant people refusing? What are some factors at play?
I think it's a little bit of all of that, just depending on the person. Some providers aren't really aware of requirements, or aren't or best practices for sexual health related conversations or testing. Some folks don't think it's important, or maybe they don't think they have a risk. Some doctors also assume that certain people, if they don't have risks, by not talking to them. As an older woman, nobody ever asked me about my sex life, right? So nobody knows what my risk. Of course, I'm not having a baby, right? But these things happen. And then, the things that we mentioned, that sometimes people don't get into prenatal care because of substance use. Sometimes they got tested early on, but then they had something that happened later. And so I'll stop talking and see, Victor, if there's other things you want to add as well.
That is a great question. It's kind of similar, a little bit of both. Sometimes even when folks go in and they report to only having one sexual partner, provider sees risk factors, no drug use, and it's a lot from their people answering on the questionnaire before they're being seen. And sometimes people don't want to talk about their substance use or want to talk about multiple sex partners, so they put one. And clients are like, well, they didn't test me for syphilis, but I do have it. Why is that? And we talk about risk factors and we find out, there are multiple partners, or they're doing things that they're not reporting. So a lot of that self-reporting does get interpreted to providers saying, well, I don't see much risk factors, so we're not going to. Or, if they are automatically, if I've noticed some folks who are in stable housing, sometimes they don't get seen because it's like, well, will they come? Will I've had conversations with some providers saying, well, they might not come back. I'm like, well, how can we fill in that gap? How can we eliminate that thinking? And we can provide transportation to bring to you. Let's work together.
Thank you so much both for that question. And I'm gonna end it on our final question because I want to be respectful of everybody's time. I'm sure this is probably for Victor. Do you ever use health warning letters through the local health department to get pregnant patients in for treatment? I'm sure Renee, you can also talk about this.
There, um, every health jurisdiction has their own standing orders in terms of treating. There are some counties, some local health jurisdictions that don't treat pregnant people. They tell them to go to infectious disease, or they tell them to go to the hospital to treat. They don't treat, unfortunately. There are some other local health departments that do treat. And because the OBGYN does not have the Bioslin on hand, they're able to say, bring them in for us. We can be able to provide treatment. So you get a little bit of both worlds. It's unfortunate for the county that we do try to help. So it's yes in some areas and some no in some others. So that's the benefit of working in rural areas is that it's not consistent. Every county is different, even though they're neighbors. Every county is different.
Renee, do you have anything you want to add to that?
No, that's my same experience. It just depends. That can vary very much. So I guess the good thing is to learn and know what your health department has available or not, or how they handle things when you have an opportunity to do so.
Also, I lied. We are ending on one last question because I think it highlights partnership, and I want to end on that. We have one last question in the box that we're saying, are the DIS disease intervention specialists networking with other services such as WIC or service for re-interview?
We we do try. We do get a lot of pushback. So I know one of the counties, two of the counties that we do serve, they're fortunate to have a staff work with us and be able to like, oh, how can we locate this individual? If there's a prenatal care going on within these two counties, we're willing to work side by side with her. It's just about communication and getting out there to meet, to show people who you are. Because a lot of programs such as WIC come in, and I first started this position, a lot of people are like, oh, well, we've met so many people. What's going to make you different? It's like, well, you're going to see me more often. You're going to see the ability that we can work and engage together and just keeping that network open.
Perfect. Renee, do you have any closing thoughts about that?
Yeah, it totally depends too. So I have been able in one health department to get like priority services for people who want to get on birth control if they are newly diagnosed with hepatitis C and have a substance use disorder, or working with WIC in one health department. They were interested, even though they have some rules and regulations that can make it tricky for WIC to start introducing other things into what they do. So it just really depends on relationship building and how open someone in another program is. And sometimes those are run by outside organizations. Sometimes they're inside the health department. And so it can really, all of this really varies and just trying to know your local services and what can be done. And when you have the opportunity to bring people together and be thinking about the whole big picture for the people that you take care of, not just the one thing that they need.
Awesome. Thank you all so much. With that, we are going to end the webinar. We will see you hopefully next week, same time, same link. You will get an email reminder from Zoom. If you have any questions, Renee and I can be reached. Martha, go ahead.
I just wanted to say thank you to our interpreters at Language Access Austin for helping us out today.
Yes, thank you so much for Language Access Austin and our interpreters. We will see you all next week. I hope everybody has a lovely day.
Thanks, everyone.
Bye.